Welcome and thank you for joining us today. The American Society of Transplantation is proud to present today's webinar on development and deployment of AI tools in liver transplantation. This webinar is part of a series of educational offerings on the applications of AI to transplant, developed by AST's Transplant Administration and Quality Management COP and the Thoracic and Critical Care COP. Today's session is sponsored by AST's Liver and Intestinal Community of Practice. In a moment, I will turn the session over to our moderators, Dr. Bruce Gelb from NYU Langone Health Transplant Institute, and Dr. Alexandra Strauss from Johns Hopkins University School of Medicine. But before we begin the main presentation, we do have a few housekeeping notes to help you engage with today's session. There's currently a viewership polling question displayed for our attendees. Please take a moment to answer this question while we finish the remaining announcements. This webinar is being recorded and the archive will be available on the AST's YouTube channel 2 to 3 business days after the live session. Please note that all of your lines have been muted so that only the panelists can be heard clearly for the archive recording. If you have a question for our panelists at any time during the webinar, we encourage you to participate by using the Q&A button in the Zoom webinar panel. Questions submitted via the chat window may be missed during the presentation. Finally, when you log off at the conclusion of today's webinar, you will see a link to a short evaluation survey to complete. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to our moderators, Drs. Gelb and Strauss, to begin our presentation.
Good morning and good afternoon, everyone, depending on where you are in the country. Welcome to the AST series on AI applications in transplantation. The series launched several weeks ago with a session by Dori Segev, who provided an overview of artificial intelligence and machine learning, and then that was followed by 2 webinars from cardiologists from Penn and Mayo Clinic, and they presented their work on applications in AI to heart transplantation. And since then, our most recent webinar was done by Dr. Ali Strauss, who's moderating today, and she moved below the diaphragm to discuss applications in AI and liver transplantation. And we follow that today with a session from Dr. Mamatha Bhat, presenting on AI tools that can be applied to liver transplantation. The purpose of this series is to really introduce and gain understanding of a very new and emerging technology, AI. And I think of this much like when iPhones came out and everyone thought they were either the greatest thing in the world or the worst thing in the world. But let's face it, they're here to stay, and this is the future, and we're going to have to embrace it. And I think this is really going to advance not just medicine, but in particular the complexities of the field of transplantation. And with that, I'm going to turn it over to Dr. Strauss to introduce our speaker for today.
Thank you. It's my honor to introduce Dr. Mamatha Bhat. She is a hepatologist and she leads the Transplant AI initiative at the University of Health Network's Alexandra Transplant Center. She is an associate professor of medicine at the University of Toronto. She completed her medical school and residency training at McGill University. She then completed a transplant hepatology fellowship at the Mayo Clinic in Rochester, Minnesota, followed by a Canadian Institutes of Health Research Fellowship for Health Professionals, through which she completed a PhD. The goal of Dr. Bhat's research program is to improve long-term outcomes of liver transplantation through a precision medicine approach. Her program is unique in using tools of AI with bioinformatics to personalize the care of liver transplant recipients based on an improved biological understanding of the liver and disease after transplant. Her interdisciplinary program has been supported by the Canadian Institutes of Health Research, the Canadian Donation and Transplant Research Program, Natural Sciences and Engineering Research Council, the Canadian Liver Foundation, among others. Dr. Bhat is the Partnership and Engagement Lead for Timurti Center of AI Research and Education in Medicine. She is the chair of the International Liver Transplant Society Basic and Translational Science Research Committee, and she's on the executive committee of the CDTRP and an associate editor for the American Journal of Transplantation. Dr. Bhat has also been the recipient of recognitions such as the 2022 CIHR INMD CASL Leadership Career Research Prize, the CASL Research Excellence Award, and the 2021 American Society of Transplantation's Basic Science Career Development Award. So, without further ado, I'd like to let Dr. Bhat take the stage. for her presentation titled The Development and Deployment of AI Tools in Liver Transplantation.
Thank you so much, Dr. Strauss, for that kind introduction, and Dr. Gelb for moderating along with Dr. Strauss. So it's a real pleasure, and I'd like to thank the organizers for the opportunity to present today's webinar as part of the AI and Transplant webinar series. I think it's really an exciting time for AI in healthcare. There have been so many developments in the last few years, and I think the future is really exciting, as Dr. Gelb was saying. So here are my conflicts of interest. My research program is also supported by various grants, which I'll mention and acknowledge at the end. These are our moderators' conflict of interest disclosures. So this is the outline of my talk today. I think, Dr. Strauss did such an excellent job going over liver transplantation, applications of machine learning in liver transplantation, and really the, whole background around machine learning in general. So what I'd like to do in this talk is dig deeper into specific cases of projects wherein we have developed tools of AI really suited to the clinical nuances of the question. And so I'd like to speak about some lessons that I've learned over the course of working very closely with computer science academic colleagues, so computer science professors who are able to develop new AI tools to suit the clinical nuances of a specific question. And so I'll start off by talking briefly about machine learning in liver transplantation, just to quickly set the stage for those of you who were not present at our previous webinar by Dr. Strauss. And then I'll speak about specific examples from my own research to just demonstrate how specific tools can be developed for specific issues in transplantation. And I hope that gives you some perspective as to how, it's possible to develop such new tools and why this requires very close crosstalk and working with computer scientists. So we'll talk about achieving equitable prioritization on the liver transplant waitlist, optimizing post-transplant survival, as well as graft survival in liver transplant recipients, and finally, clinical deployment in implementing AI algorithms in transplantation. So why machine learning in liver transplantation? I think, as a hepatologist, what really fascinated me when some key papers came out. So there were some key papers in 2017 that came out that really inspired my interest in applying AI in liver transplantation. The reason for this was they were talking about imaging patterns, so say skin cancer and diabetic retinopathy, so pattern recognition, and how this could be, how AI could be leveraged for pattern recognition to diagnose specific imaging-based conditions. And so right now, there are close to 700 FDA solutions that are principally imaging-based. So radiology, 76% of those FDA-approved solutions are radiology solutions. Now, if we talk about liver transplantation specifically, there's so many different factors beyond imaging that really are considered in our day-to-day practice. So we think about, various clinical characteristics. We look at complex nonlinear patterns in liver enzymes, liver function tests, and various blood tests. And then we also will consider various imaging data, so radiomic features, histological features. So there are different, say, types of data that we are generating in our day-to-day practice that could then be, say, integrated all together for personalized predictions. We also are generating lots of molecular data, especially in the research context, which will have, future applications in precision medicine. So when we generate all these data, it's clear that a hepatologist looks at patterns in these data, tries to generate personalized predictions for the given patient in front of them. But the reality is that the human brain can only really consider 4 variables at a time, notwithstanding longitudinal changes in those variables. So this is where AI tools can come in and really, decipher that complexity, integrate all these different types of data to then generate personalized predictions. And, it's really not possible for the human brain to do this, but the AI tools can serve as co-pilots in the care of patients. And so when we look at liver transplantation specifically, we have the opportunity to also bring some objectivity to certain decisions that are made in liver transplantation, including the identification of suitable donor organs, waitlist prioritization, donor-recipient matching, and prediction of outcomes. And so, there was some key landmark work published by Dr. Buccino and colleagues in Journal of Hepatology back in 2014, and subsequently there have been various papers looking at different, say, topics within applications of ML. And so we have summarized this, increasingly robust literature in liver transplantation in a review published in Journal of Hepatology last year. I think AI tools offer us the opportunity to also model dynamics and individual trajectory. So if you look at longitudinal data over time, the reality is that a patient has dynamic changes in their clinical condition over time. So particularly on the wait list, when you look at patients who have acute on chronic liver failure, or they develop a decompensating event or a series of decompensating events. The reality is that there are dynamics in that patient's health over time. And certainly this is, quite amenable to deep machine learning tools that really can integrate all that longitudinal data. So using the past to then inform the future. Looking at optimizing survival in liver transplant recipients, these are the broad categories, and certainly there has been literature in this regard from various groups. So in post-transplant survival, optimizing graft survival through donor-recipient matching, and HCC recurrence prediction. So now what I'll do is really, as I mentioned, dig deep into designing specific solutions for specific issues in liver transplantation. So one, interesting and important problem in liver transplant prioritization and allocation has been the inequity in specific subgroups and their prioritization on the wait list. So certainly we've known over time that the melsodium system was disadvantaging female patients in terms of their ability to attract organ offers. Now, the MEL 3.0 certainly rectifies this to some degree, but not completely. So this is one area where there is opportunity for further improvement. Additionally, there are various subgroups, including those with primary biliary cholangitis, as well as acute on chronic liver failure, small statured individuals who are also disadvantaged. And certainly there's been a shift in the underlying patient cohort over time. So it's important to consider, say, a tool, a model that is better able to simulate and model those dynamics, as well as account for groups that are currently disadvantaged. And so this, really inspired our work. So this was driven by a PhD student, Michael Cooper, co-supervised with a computer science professor with whom I work closely. And so our hypothesis was that some of the present inequity stems from inaccurate modeling. And so, Michael actually joined me in the liver transplant clinic and really acquired a deep understanding of the clinical nuances of this problem. And he was really inspired to look at developing a solution that would attempt to rectify these issues of inequity. So with that deeper understanding, he was able to look into developing solutions that address the clinical nuances. So he trained a deep learning model on over 53,000 patients listed for transplantation in the US since 2016. These were patients with decompensated cirrhosis and without exception points, and he considered 13 static and time-varying covariates per patient. So these included laboratory variables, as well as indication for transplant and sex. And so these were all considered as time-varying covariates, if applicable, as well. And so this was the data set and cohort. So 54 years of age, 43% female, male sodium median was 22 at listing, and these were the indications for transplant, as expected. So he called this model a nonlinear dynamic model of end-stage liver disease, or DynaMELD, for accurate and fair risk assessment. And so if you look at the traditional MELD model, it is a Cox-PH linear survival analysis model. And so he decided to use, and he evaluated different DeepML algorithms, but he decided to use a DeepServe algorithm, which was then modified to include rate of change variables. So both velocity and acceleration of laboratory variables over time. And so this was incorporated into the model at every time point on the wait list. And so with that, we were considering a nonlinear neural network, a more recent cohort of patients. Certain characteristics were included that were beyond the standard, and we also included rate of change covariates. And so the evaluation of this model was through a 90-day concordance index, which is the concordance between ordering by risk score of the patient and ordering by observed time of death within 90 days. And so this is similar to an area under the ROC curve for right-censored patients. And so a strong performance would be 0.8. And so certainly this was achieved. So the concordance index of DynaMELD on a held out validation data set was 0.818, which was significantly higher than current standard of care, the MELD 3.0. And then if we looked at specifically the fairness measure, so there's a specific measure of fairness called the Pooled Group Concordance Index. And this is concordance over pairs, where the first member is part of a defined protected group. So this is women or PBC patients, or ACLF, or short stature. So these are all various patient subgroups that are relatively disadvantaged on the wait list. And so we looked at fairness for these different groups, and we determined that this model was certainly higher in terms of PGCI, or Pooled Group Concordance Index, for women, for those with primary biliary cholangitis, as well as those with small stature. We also determined that those with ACLF, so acute on chronic liver failure, were better prioritized and DynaMELD was more reflective of their severity of illness as well. So this is something we also looked into in terms of reclassification of decedents, and we found that overall 129 more decedents were placed into a higher risk tier. Now, we then looked at external validation in our own institutional data set, and certainly this algorithm was able to perform similarly well in women, as well as those with primary biliary cholangitis. So now looking at Shapley analysis. So this is a way of determining, well, you know, I have a patient with a certain prediction of outcome. So they have a certain prediction of waitlist mortality or dropout on the waitlist. So why is it that that particular patient has that high or lower risk of waitlist mortality / dropout? So this is where you can do a Shapley analysis to determine what are the top variables, either modifiable or non-modifiable, that are predictive of that outcome. So in the overall cohort, we certainly determined that patient serum creatinine, bilirubin, INR, albumin, sodium, as well as patient sex were the topmost features. So, you know, a large majority of patients certainly were well served by these parameters alone. However, there was a subgroup of people for whom certainly the first order change, meaning the velocity of the serum sodium, serum creatinine, albumin, bilirubin, were quite important in terms of their own risk assessment. And, this just goes to show that, incorporating these additional variables into our scoring system, into our prioritization, would certainly be of benefit for specific patient subgroups. And so I think what then you can do is understand, okay, well, what is the individual weight of each of these features? So for example, if you have, a patient with these various features, and you can determine, well, what is the weight of their serum creatinine, their sex, their albumin on ultimately their risk on the wait list. And so there's this ability to obtain individualized interpretations, and you can then say, understand, how it is that your given patient is at higher or lower risk. And it gives you a certain degree of confidence and trust in the prediction, which you otherwise might not have if it's simply a black box model with no list of predictive features. And I would say in my own experience, I found this to be very helpful, because I would have more difficulty in trusting a prediction if I wasn't given a list of features that really accounted for that prediction in a given patient. So now I'll move on to post-transplant patient survival, and we have published a few papers in this regard, and so I'll get into one specific example again that highlighted will highlight some of the lessons that I learned through this experience. So, as all of you know, the median survival of liver transplant recipients could actually be much improved or much better than it currently is. In the Canadian population, we have estimated that the median survival of liver transplant recipients is actually 20 years less than population average life expectancy. And this is compromised by a heightened incidence of cancer, cardiometabolic disease, and infection. And due to existing comorbidities coming into transplant, as well as the lifelong immunosuppression that patients are on. Currently, the care of our patients is based on limited evidence, and we tend to, manage patients based on, experience, as well as, say, lessons taken from the non-transplant setting, etc. So, how can we better manage and help our patients optimize their outcomes after transplant? Because clearly there's much more work to be done. So this is really, what inspired the project that I'll talk to you about. So, how can we change this and turn transplant into a cure? This long-term survival beyond a year has not improved in the last 3 decades. So what can we do to transform this and change transplant into a cure? So this was a paper that our group published in Lancet Digital Health. So it was a co-senior authored paper with Bo Wong, who is chief AI scientist at our University Health Network, and was driven actually by, interestingly, so an undergraduate student in computer engineering, along with a clinical research fellow, so Oswald Nitsky and Amir Ajay, and they worked very closely actually to understand each other. And understand each other's points of view in order to drive this project forward. And I would say, it was critical also for Bo Wong and myself also to understand each other and, teach each other about, say, the clinical problem from my side, and from their side, they had to understand, what are the nuances of the question and what is the best way for us to address this question. So, our plan was to develop a long-term mortality risk stratification of liver transplant recipients using deep machine learning algorithms. So we looked at annual follow-up visits and looked at several variables, including those from the Scientific Registry of Transplant Recipients, and then in the external validation set, various specific more granular data points in our own UHN data set. And we looked at overall survival and survival compromised by graft failure, infection, cardiac event, and cancer. And the idea here was to develop a more personalized risk calculator to manage long-term transplant care that could be used at each follow-up visit. So we incorporated longitudinal data over time to give real-time predictions at each clinic visit so that we could project forward at 1 and 5 years from the given visit. And so we use the scientific registry of scientific registry of transplant recipients. So we trained the model on over 42,000 eligible liver transplant recipients, and then tested it, so performed external validation in our own institutional data set. And we determined that the best deep machine learning model was a transformer model, which is quite a heavy-duty deep ML model that allows you really to work with longitudinal data, understand patterns in that data to predict into the future. So overall survival area under the curve was 0.77 for 1 year and 0.71 for 5 years survival prediction. And then you can see that the various types of cause of death were better predicted with the ML model as compared to, say, logistic regression overall. So, and then we performed the external validation of this work using our own institutional data. We then were able to identify the ranked features or the top variables that were predictive of outcome for the overall cohort. And finally, we are now deploying that tool, which I'll get into in the last section of my presentation. So now I'll talk about developing a tool specific to predicting graft fibrosis. And so, as you know, in liver transplant recipients, patients have accelerated development of graft fibrosis over time. So whereas in the non-transplant population, it takes 20, 25 years to develop cirrhosis, in the liver transplant recipient, unfortunately, it can be as short as 5 to 10 years after liver transplantation if there is significant inflammation in the graft. And so it's quite important for us to understand who are the patients who are at higher risk, predict those who are at higher risk of graft fibrosis progression over time. And so what are the methods that we have available to diagnose and predict progression of graft fibrosis? So we have basic serum biomarkers, which have relatively poor specificity, and then you look at imaging methods such as transient elastography and MR elastography. So these certainly we can use in the clinical setting, but may not be widely available at institutions worldwide. So what we were interested in developing here was a framework for dynamic diagnosis of graft fibrosis. So this was driven by a computer science postdoctoral fellow who is now a professor, Divya Sharma, who worked again closely with my clinical research fellow to develop a deep machine learning model, so it was a new method that she developed to suit the specific nuances of the data set that we were using. So she considered longitudinal, demographic, clinical, and laboratory test variables and integrated this using a deep machine learning framework to detect significant graft fibrosis. And the reference method was liver biopsy. So she was looking at 1,893 liver biopsies and had a training set and a test set, as well as a validation set. And a total of 29 variables were considered, including longitudinal changes thereof in those variables. So she trained conventional machine learning algorithms. So your basic off-the-shelf machine learning algorithms, as well as deep machine learning algorithms. But then she thought that this particular question, as well as data set, could benefit from some methods development. So this is where she then developed something called weighted LSTM, or weighted long short-term memory networks, which is a new method that she developed for this specific question, which is able to better train on cases versus controls. So it trains more on cases because there was an imbalance in the cases versus controls. It's better able to handle missing data. And then it also improves the standard LSTM so standard long short-term memory network, which is a type of deep ML algorithm, through a certain weight loss function to minimize bias. And so the performance of this algorithm was quite good. So with an AUC of 0.798, and it had 100% determinate, sensitivity was 78.8% and specificity of 81.4%. And this was certainly better performing than standard serum biomarkers. We also evaluated its performance. I don't show that data here, but basically we evaluated its performance against transient elastography, and it performed similarly to transient elastography. There was no significant difference in its AUC. The top ranked features are listed here for the overall cohort and include recipient age, transplant primary indication, and donor age, which actually makes sense from a clinical intuition perspective, as well as based on the clinical literature out there. So again, providing that sort of trust in an algorithm's prediction. And so here is what a clinician would see. So for example, you have an output of this particular algorithm on a dashboard, and you're able to predict that this particular patient has a high risk of advanced fibrosis, so stage 2 or greater fibrosis at this follow-up visit based on their parameters. Now I'll move on to the final, method that I'll talk about that, again, is designed based on the nuances of the question. So this is, again, a method that was developed by the computer science postdoctoral fellow on my team. So she developed a diagnostic tool for graft pathology called GraftIQ. And the inspiration for this was, again, clinical experience. So, we see many patients with elevated liver enzymes over time. Over 50% will have elevated liver enzymes at some point in their post-transplant trajectory. And so they'll undergo an ultrasound with Dopplers, followed by liver biopsy, standard serologies being tested, etc. But certainly this is invasive. There are multiple risks associated due to its invasiveness. And so, I was quite intrigued by this problem because I felt like this is something we were doing in practice. So I would, have a certain hunch. All physicians will have a certain hunch. What is the likelihood of this being rejection versus biliary obstruction versus MASH, which is a longer term issue, or CMV, hepatitis, etc. So a physician will have a certain hunch based on the patient profile and test patterns. And so, this is an example. Say a young liver transplant recipient has elevated liver enzymes, ALT greater than AST, plus elevated alkaline phosphatase, most likely to be acute rejection. So this was the inspiration for this particular project, wherein we aim to develop a multi-class machine learning algorithm. So multi-class, not just looking at binary outcomes, but really like classifying patients into different potential categories of graft injury. And so this algorithm was trained on longitudinal data over the week preceding the biopsy. And these were biopsies performed at our institution over a long time period, so 1987 to 2020. Actually 2022, this slide needs to be updated. But basically these patients were divided into different histological categories. So what Divya found actually was that an artificial neural network was the best performing model for the diagnosis of these different classes of graft injury. And these were the SHAP analysis results. So the top 10 predictive variables for each of these types of graft injury, so acute cellular rejection, alloimmune hepatitis, biliary complications, congestion, recurrent hepatitis C, and MASH. And so then we went on to perform an expert versus machine, so a medic versus machine implementation analysis. And very interestingly, the ML model was actually much better than the medic for various categories. It was less good at acute cellular rejection. And in fact, it was interestingly like very poorly performing on some cases of rejection that I would have said were quite straightforward. And in fact, the clinicians got those cases, easily. So, so overall, ML model was better performing. It exceeded hepatologists in every evaluated category and we had chosen 30 cases with all the blood tests as well as clinical characteristics that had been fed to the model. And then, I told Divya, I asked Divya, why don't we feed or teach the algorithm these clinical, say, decision rules that we hepatologists have. So, in order to improve its performance, particularly in terms of acute cellular rejection, I told her, these are the types of test patterns. You tend to see this in the first three months post-transplant, 3 to 6 months post-transplant. So I gave her certain, clinical rules that she then fed back into the algorithm. And so what she used was some Bayesian inference principles to apply and fuse this prior knowledge provided by clinicians with the likelihood provided by the artificial neural network model. And then the integration was achieved through a weighted combination of probabilities generated by the machine learning model and the clinician. And so she determined, so I hope you can see this, but basically the AUC of the improved model that integrated clinical insight was actually better performing, statistically speaking, it was better performing than just the multi-class neural network model. So enhancing its performance using the clinical insight, so clinical rules that we had fed it. So, basically illustrating this human in the loop concept that you can use to then improve model performance over time. And so now I'll conclude by talking about clinical deployment, so implementing AI algorithms in transplant. I think this is really exciting. Certainly, this is beyond the scope of this talk, but certainly there are algorithms that are already deployed in the general medicine world to, say, predict sepsis, predict the risk of deterioration of a patient on the ward and their risk of going to the ICU, et cetera. So there are these tools that are out there and are being deployed to improve patient care. This has been a bit slower, at least in liver transplantation. We are still in the early stages, I would say, in terms of implementing AI algorithms, but certainly that experience is being, say, developed as we speak. So I think, it's really exciting. So overall, the phases for development and adoptions of machine learning solutions include an exploration phase, so which is identifying and understanding the issue, establishing a team of clinical experts, which includes physicians, nurses, so stakeholders from a clinical healthcare perspective who are very interested in helping improve healthcare outcomes. Then the data engineering team and a machine learning analysis team, a human healthcare factors team, so like cognitive psychology or behavioral psychologists. So there are different, say, types of people and types of expertise that need to come together. One needs to specify the outcomes of interest, understand the workflow so that the solution won't interfere in day-to-day patient care and rather will alleviate work burden. Identifying the interventions, envisioning a future state, and exploring data feasibility. So this is the exploration phase. Then there's the solution design phase of the machine learning solution. So developing the model, testing the model, developing a user-friendly tool, so a dashboard that is easy to use, and then testing in a silent phase. And then finally, you have the implementation and evaluation phase, so implementing a solution iteratively and considering phased implementation. So there are various clinical trials going on of AI tools, many of which now are recorded in clinicaltrials.gov, which I think really speaks to the interest in evaluating in a systematic way the, say, performance of these tools and how these could really impact clinical care. And so overall, you see, so these are the various steps in the process, and they require end-to-end patient and clinical clinician involvement, nursing involvement. Overall, you need to want to address an important area of need in the field, model building and development of a dashboard, and ultimately silent testing of the algorithm in comparison to standard of care. And so coming back to our post-transplant mortality risk stratification tool, so survival stratification tool, this is an example of the dashboard we have deployed in our clinical setting. We have facilitated, say, the transfer or the data flow from Epic, as well as our historical transplant database into a cloud on a nightly basis using Clarity software, and then have that data fed back into a dashboard that is really deployed from Epic. So we click on an icon in Epic, which then deploys, and then basically it's able to generate these personalized predictions for every given patient and understand what are the individual risk factors which are either modifiable or non-modifiable and their role in prediction. And so ultimately, the clinician will see these 1 in 5 year probabilities of each outcome, the ranked features for each outcome. A high prediction of a cardiac event could serve as a red flag suggesting specialist referral, etc. And we are tying this into standard operating procedures for post-transplant care based on risk. And so here you can also even modify the variables and understand what might be the changes in future outcome if I were to modify, say, someone's tacrolimus level by this much, this percentage or that percentage. You can do that, but I think at this point, it's kind of difficult to say if that is accurate or not. I suspect not, but this is something that we're very excited to evaluate prospectively. We have the opportunity to bring in new variables into the model and continue to teach it and to train it over time. So for example, if we initiate a specific intervention for a specific increased prediction of cardiovascular event, then you could add that as a variable to the algorithm. And then this is the list of ranked features. So this is the data pipeline. So I spoke to this already. This platform will connect data from both existing and historic systems. The front end is built as a progressive web application, which involves human factors design. And its successful implementation is feasible when there's clear communication among key stakeholders across the institution, requires an experienced data engineering team. And I think overall, these are our goals for our current model deployment, and certainly the other models that we have published or are working to publish now are certainly tools that we are planning to bring into the clinical setting so that we can again optimize outcomes. And these include, say, models that could optimize immunosuppression dosing practices, predict onset and progression of kidney disease, as well as predict risk of deterioration in transplant recipients. So these are different types of algorithms that I think will be helpful in terms of improving healthcare outcomes in transplant recipients. So I think now I'll conclude by just talking about something that's very happening in the AI and healthcare field now. So a lot of talk about this buzzword, which is multimodal AI. And so multimodal AI models refers to the integration of so many different types of data. So the human clinician actually is considering so many different types of data at the same time. So you're familiar with all of these different data types. So as a patient comes into the emergency room, they have, an ECG, a chest X-ray, beyond the blood tests, and then their, moment-to-moment changes in their blood pressure, et cetera. So there's all this diversity and complexity of clinical data that can be integrated and analyzed for better predictions. And so multimodal AI tools, there are different models that can be used to, say, bring together all these different pieces of data. And it's been found that such models do have predictive performance that is better as compared to single modality and can compensate for missingness by using complementary modalities. So I think overall, my vision for the future of AI and transplant is really this ability to personalize the care of patients, to predict trajectories and dynamics, whether it's pre or post-transplant, and really optimize the care of liver transplant recipients so that they can enjoy the best possible benefit of their gift. And so I think there's a lot of exciting work that we all can do together to really optimize outcomes. AI, I think, holds tremendous promise for us to do so. Bringing together all these different data types, I think, is key to then allowing us to personalize the care and practice more precision medicine, whether it's clinical data, omics data. Large data sets are needed, multi-center collaborations are needed, and clinical deployment, I think, is certainly very exciting. Prospective validation is going to be required to be absolutely certain that this is safe and will help improve outcomes in our quite complex liver transplant population. So as mentioned earlier, I co-lead the Transplant AI initiative at our center with Dr. Aman Sidhu, and we work closely with Dr. Mike Brudno, who's chief data scientist at our institution. We have a team of ML analysts and data engineers, and I'd like to acknowledge key collaborators in developing specific AI models, my clinical trainees and ML trainees, as well as translational research team, and our funding sources in performing this exciting work. So thank you so much for your attention, and happy to address any questions and look forward to the discussion. I'm happy to address questions by email, and we certainly have positions for clinical fellows or computer science postdocs who are interested in learning about the exciting world of deploying AI algorithms. Thank you.
Great. Thank you so much, Dr. Bhat. What an interesting talk and quite informative. I think you're showcasing how much AI is actually going to integrate in transplantation in the future. To everyone who's attending, if you have questions, please submit them through the Q&A session, and we'll try to get them during our discussion point, which will start now. So one of the first questions that I have for you is primarily how we deal with AI and PHI and the complex regulatory systems that we have. And a lot of the studies that you've done are geared towards single centers. So it's an internal to the walls of the hospital where it's being used, much easier system. But when we talk about the transplant system as a whole, organic knowledge, particularly with these neural networks, if we're looking at Dynameld in the future, how are we going to be able to integrate AI in the current regulatory system?
So thanks for this. It's a very important question. I think in terms of training models, there are different approaches that you can use in order to not have to transfer data from one institution to the other. So there is this approach called federated learning, which allows an AI model to train at different centers simultaneously, and then you kind of bring it all together for predictions. And so it's not necessary to then, say, share data from one center to the other. Another approach is so to prevent data leakage and so on, to prevent any concerns in that regard. The other thing that one can do is actually share the AI model with another institution. And certainly this is something that my group has been discussing with other institutions in the US, which is like transferring our model. Our models are basically, like, some of them are already published on GitHub. So basically transferring those models and then seeing how they perform with the local data. So then we do away with any concerns around, data leakage, patient privacy, etc. So I think, from a research perspective, and in order to drive the AI and transplant field forward, there are different approaches that we can use, to really ensure that these models are able to work in different settings and can be used to optimize outcomes. Now, Other than that, in terms of PHI, I think there are certain, say, standard considerations around the handling of, data privacy, and maybe Dr. Strauss, is an expert also in this regard. So if you'd like to comment further. Oh, you're muted.
Sorry. I think I would just add, I agree with everything that you just said. And then in terms of, thinking about the future of research, the future of AI, and applying these in clinical care, if you compare it to what we currently do, in some respects, we're able to have better data privacy and better protection. If you think about right now, our processes for research are, students, whether it's postdocs or med students or engineers, but you have these people pulling data from medical charts on an individual basis, saving them on their laptops, and then those can potentially be lost. The data can disappear if someone leaves the institution. So in some ways, we're with being able to pull data directly from the back end, like you were talking about, your team pulls from Clarity and Epic background, and keeping it all in a safe environment that's protected by a university, and never having this whole process of manual chart review. Will it be able to track and audit data movement and know exactly that we're protecting the patient's data?
I think these are fascinating concepts because it's showing what the power of AI and machine learning is. We always think about when data sharing, it's an external way. You have to upload the data elsewhere, which is where we have our PHI concerns. And now we're talking about the concept of sharing a model. It's almost like a visiting professorship with a technology. And that's exactly what you're talking about, having medical students diving into charts and sifting for data when sharing an application that can learn and become more powerful in each iteration. That's such a new concept. We're so used to computers, but we're not used to sharing them externally, or we're so cautious about the sharing of data external to the walls. This may be the opportunity to be able to preserve that and gain access. We do have a couple questions in the chat box. Gita Karad Keeley asks, how about external validation on the training models?
Yeah, so I think that's quite important to say perform external validation of models that you have developed at a single center. And then if it does not validate well in that other environment, understand the reasons for which it's not working well. So you can understand those reasons and then say fine-tune that model to enable its enhanced performance in that different environment. So one should not assume that if it does not validate, that immediately the model is, just discard that model. That should not be the approach. One should actually then dig deeper into what are the causes for which this model is not performing well, and then try to rectify those issues, or say address those issues in the model. And it is very possible to do that. Of course, I'm not a computer scientist, but my computer science colleagues certainly have the expertise to say adjust the model or fine-tune that model. Now, if that also does not work, then one needs to say retrain the model in a different setting. Additional say approaches to concerns with external validation are this federated learning approach, which is a bit complicated overall to establish. But it's something that certainly has the ability to address this issue around inability of external validation.
You brought up some very important points in your talk, and that was, what's the predictability? What's the likelihood that the prediction based on the AI is correct?
Yes.
And I'm a layman when it comes to artificial intelligence. I know a lot about transplantation, and I'm a really good guesser, and my predictions are usually pretty good for a human, I guess. But I kind of equate the technology to when we look at self-driving cars. we expect them to be perfect. And when you hear in the news there's been one accident with a self-driving car,
Yeah.
it's such a terrible thing. It's a travesty. And I think we need to be cautious in AI. And I think putting the likelihood that the prediction is accurate is going to be important for people to understand where the model is. In areas where it's better than others. And I think that one of the data points that really hit me was our predictions of acute cellular rejection. Machine learning was a little better than the clinicians on it, but both of them aren't very good compared to the other aspects like obstruction or inflammatory or
Yeah.
So I think that's going to be important. And as humans, we tend not to do it. It's such a muddy thing. And we talk about the art of medicine. We don't talk about very clearly how likely our prediction is correct. So I think this is a huge opportunity in the AI sphere.
No, I think that's an excellent point, and I agree. It would be helpful to have such percentage likelihood of this prediction being correct in order to also help clinicians gain trust. And beyond that, the interpretability of the model, as I was mentioning earlier, I think is quite important, because I also, I learned to trust these models because there was that list of ranked features. Otherwise, I would have significant, I think, obviously I'm very enthusiastic and I'm biased about AI, but I think, most people would have some reluctance or resistance to trusting the prediction of an algorithm when there is no clear, list of factors that are leading to that prediction. And I think that's what's very interesting about, say, these interpretable models. And now you can do Shapley analysis with most models, so deep ML, even deep ML models. So, this field is rapidly evolving. There's new methods being, say, developed every day. So, it's just a matter of keeping up, actually. So this is why, I certainly am not a computer scientist, as I mentioned. So I rely on my computer science colleagues actually to keep me up to speed. And I would say, the postdoctoral fellows and the computer science graduate students are actually critical in keeping us on our A game overall in terms of using the newest methods, because it's very difficult as a clinician to actually keep track of what's going on.
Yeah,
So, I think it's quite critical for us to learn about these tools and learn what they can and cannot do as well. So this requires education of the physician surgical community, as well as trainees. I think our trainees, certainly many medical schools now are including AI as part of their curriculum. So I think this is, say, an excellent step forward to then educating the medical community as to the benefits and challenges and how we can surmount those challenges over time.
Just like my analogy in the beginning, the tipping point that we had with smartphones is when people gain confidence and trust. And I think that's going to be key to AI also. And we have one more time for one quick question before we close. And Zara Mohammadi asked, has artificial intelligence been utilized to predict and assist in delisting patients from transplant lists based on clinical data?
So that's a good question. As far as I know, I'm not aware of any such study in the liver transplant literature. I think you would require, say, large data sets, and that could be, something interesting to, say, interrogate the SRTR with, an interesting clinical question. Ali, Dr. Strauss, are you familiar with any papers addressing this specific question, like delisting? But the issue, I guess, is I mean, the thing is, a registry does need to have granular data. So in order to fully understand the reasons for delisting, certainly the SRTR has some level of this, but maybe Ali, do you have any further comments on that?
Yeah, I think understanding specifically about delisting, because I mean, there's obviously a lot on delisting for death. There's some people that will put delisting because too sick to transplant. So I think it depends on specifically what you're interested in and what your sort of clinical question is with when you say delisting. If that means
Delisting for
should
good
not-
is adverse. Yeah.
Right,
That
waitlist
is-
suitability, or who's going to improve and not benefit from being on a waitlist. So I think that's going to eventually push more into the efficiency side of the transplant system. Okay, we have about 30 seconds left. Any closing comments, Dr. Bhat, Dr. Strauss? I think AI is here to stay. We've shown that, and it's going to help us a lot in the field.
Completely agree.
Okay, well, thank you very much for a very, very interesting talk and another very excellent session in the series on AI and its applications in transplantation. Thank you, everyone, for attending today, and we'll see you next time.
Thank you so much. AST would like to thank Drs. Bhat, Strauss, and Gelb, and the leadership of LICOP, TxAQM, COP, and TCC COP, and all of our attendees for today's session. Please look for an email from Zoom in about a week directing you to a copy of the recording available free and on demand. Finally, please remember to complete the evaluation survey in Zoom and visit myast.org/education to learn more about and register for our upcoming webinars. Thank you all again for today's excellent session.